How many of you are in a practice that's predominantly primary care? And how many of you are in a practice that just has longitudinal relationships with patients? And how many of you are in a practice that neither of those two descriptions fit? Okay, so just about everybody here, hopefully this will be a relevant topic. What I'm going to focus on now is not so much a broad overview of palliative care or hospice. We've done that before, and I think it's still an interesting topic, but I have a bias. What I really want to focus on more has to do with the conversations that go on. How do we talk with patients about difficult topics around their health care, especially upstream when they're still fairly healthy? And so we're going to go through a few different things here. Oops. So at the conclusion of this talk, I'm hoping that people will be able to put a definition to the term advanced care planning, to describe some different types of advanced directives, and hopefully be able to model a patient-centered advanced care planning conversation. In the interest of staying out of trouble with the law, neither Dr. Merrifield nor I have any financial conflict of interest. And Dr. Merrifield and I have been part of a work group at the system level for Providence that has been doing some work, and some of the slides here really come out of that work. The ones that you really like and are entertained by, the two of us did personally. The ones that are kind of boring, the other members of the work group worked on, so just to be clear. So a couple quick questions. For which patients is an advanced care planning appropriate? All adult patients? Patients over the age of 70, patients likely to die within a year, all patients with a chronic incurable illness, even if their prognosis is years. D, okay. A, okay. So we'll come back to this at the end of the talk and see if you answer it differently or not. It sounds like I heard more A's than anything. And then the same question, this is not quite, there we go, only with pulsed forms. When is it appropriate to do a pulsed form? For all adult patients, patients over 70, if they're likely to die within a year, or if they have a chronic incurable illness, even if their prognosis is years. So we're hearing A's and D's again, but we'll come back to these later. So why do you think advanced care planning is important? Just to offer some ideas, why do you do it in your offices? Do you do it in your offices? Okay, I'm seeing heads nod. Okay.
It's an important topic to discuss.
Yeah, important topic to discuss.
To open up conversation among family and the patients, so heroic care doesn't get triggered by family that isn't ready to let go.
Yeah. So if you couldn't hear that in the back, to open up conversations between patients and families so that heroic care isn't triggered by a family that isn't ready to let go. Not all patients think alike. Yeah. So what is advanced care planning exactly? It's really focused on trying to line up that the care people receive in critical times are the care they really want if they're fully informed. And that last part is critical because a lot of decisions are made because patients really don't know the options available to them and the implications of the different choices they make. It's a way of planning for future medical care. It's advanced care planning. And then finally, it's a communication process rather than any sort of legal process. It's really about conversation. It's about having your doctor, your nurse practitioner know what you want. It's about having your family know what you want. And it's also important to recognize that these are decisions or speculations that are being made not knowing how reality is going to play out. You've seen the documents. If two doctors determine I am in a state that I will not recover from, I do not want continued life support. Well, that's not necessarily all that concrete. More than 75% of people will have some point in their life that they're incapable of making decisions for themselves. Sometimes it's acute, sometimes it's permanent. Many elderly and chronic critically ill patients really would rather not go through a lot of interventions, particularly the invasive procedures at the end of life that maybe leaves their family making difficult decisions. Evidence says many people would rather, that what they would choose at the end of life is often different than what's done. And finally, only about a quarter of people, maybe a third of people have completed advanced directives. So rather than being in the embrace of their loved ones at the end of life, they tend to face this. which at times is appropriate. Certainly if I were to go down in a code right now, I want the full meal deal, give me CPR, get me in there, but I'm in good health. I expect to recover. When you have somebody that has multiple chronic, complex, comorbid conditions, and dying is not an unexpected outcome of the natural trajectory of their illness, do we really need to flog them on the way out, to put it bluntly? And so finding that right balance, not withholding beneficial, life-extending, quality of life improving care, but doing so in a way that really recognizes the complexity of it. Where do people die in the U.S.? Still about 50% die in the hospital, about a quarter in the nursing home, and about a quarter at home. About 40% in hospice, and Lisa, is that number still accurate? About 40% in hospice? Okay. So a couple of caveats on this. This only looks at where they died. It doesn't tell you what went on in the preceding couple of weeks. So the people that, are in a nursing home, they get transported to the ER because they spike a temp, they've got aspiration pneumonia, maybe they go through a lot of inpatient stuff, and then they get discharged for hospice care. None of that's accounted. This is only looking at where they die. And is death in the hospital appropriate usual care? Well, it's always going to be a certain amount of folks. Traumatic death, acute illness, even in a perfect world, I think the best estimates are anywhere from 60 to 80% would be the highest possible penetrance of hospice, because a lot of illness is not declining in such a way that you could predict it in a way that hospice would be appropriate. So in the hospital, there's a lot of invasive procedures that are unpleasant. If you have an acute gallbladder attack or appendicitis, the pain, the invasiveness is appropriate because you're going to recover and return to a normal state of function and health. So that temporary setback makes sense. If dying is the natural outcome, do you need to go through a lot of these invasive and unpleasant procedures? In the hospital, communication is really variable. Some hospitalists do a fantastic job. I sat in with a critical care doctor yesterday who did such a perfect job of projecting compassion, clarity of information, and respect for the patient. I thought, boy, if every doctor communicated like this, so many of our problems would not be an issue. But it's variable. You don't know how the people are going to communicate when patients and families are facing really hard decisions. And the emotional burden. You see a lot of tears in the hospital. I've sometimes joked that it's a weird job I have where on a typical day I elicit tears out of at least 2 or 3 different encounters. But it's the nature of the work. It's a stressful place to receive care. And then finally, in the hospital, it has adverse both quality markers. You have an increase in your mortality rate if you don't code it certain ways. And fiscally, often they exceed their Medicare DRG caps, or maybe it's a 30-day readmit and there's not going to be any reimbursement. So nobody wins if we're not aligning patients' goals with the most appropriate care. Definitions of quality of care at the end of life. Most people would say that they want to receive adequate pain and symptom management. Although they would like to have their life prolonged, they don't want to have the process of dying prolonged. They want to have some control in their life, and they really don't want their loved ones to be heavily burdened by this. And most importantly, for many people, they want the process to help strengthen their relationship with loved ones. So at the very least, we need to provide care in a way that doesn't provide barriers to that. We don't need to hold on to sort of false hopes, if you will, to such a state that people don't get the chance to work through some of the things that are really critical developmental milestones in end-of-life care. Complex chronic illness continuum makes this a little bit more of a challenge. So again, you get people who are in normal state of health, especially if you're in a long-term relationship with your patients. They develop a stable chronic illness, let's say diabetes, or better yet, metabolic syndrome. It evolves over time. They start to get atherosclerotic disease, cardiac disease, kidney disease, some peripheral vascular disease, and it becomes more of a complex active chronic illness. And then the kidneys start to fail, pump function starts to fail, their ejection fraction goes down, their PFTs start to decline, and it becomes a declining chronic illness. And finally, it evolves into a terminal illness and end-of-life care. We can enter advanced care planning in any stage of this continuum, but how we enter it is going to vary based on the patient and their needs. Oh, that's right. This one has this tricky stuff. So cancer this is oversimplified. I mean, cancer tends to have a relatively predictable downward trajectory. It's probably more of a long-term plateau until the final course that didn't succeed works. but it gives you an idea, whereas some other conditions, heart failure, COPD, and others, tend to be much more up and down. Neither of these lines are perfect. The second one, you probably don't return that close to baseline after your acute COPD exacerbations or CHF exacerbations, but gives you at least a sense of the varying trajectories. So how to define palliative care? And I'm just going to read this slide to you. I don't normally like to do that. Palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. What I like about this definition is it's less about who's providing the care than it's about what the patients and families are receiving. A lot of definitions of palliative care come in, it's provided by an interdisciplinary team and other things. It's about the medical providers, the care providers. This really focuses on what do the patients and the families need from us. I highlight that because everybody who cares for patients provides some palliative care. Just like you don't need Mike Shannon for every one of your diabetic patients, you don't need a palliative care consult for every patient that needs palliative care. You do the majority of palliative care. And then just like you've got those diabetics that you're really glad Mike Shannon's in town and you can send them to him, you're going to have certain palliative care patients that it would be really nice to have those services. Unfortunately, we're limited still to the inpatient setting in hospice, and Lisa's going to talk a lot more about hospice. We do have work afoot to create an outpatient palliative care option, hopefully within the next year, year and a half, but I don't want to get ahead of myself. Oops. These slides here, this is just, Lisa has a similar slide in her, so I won't belabor this. It just, key thing here, people often associate palliative care exclusively with end-of-life care, with hospice, with the final days, weeks, perhaps months of life. What this highlights is there are many chronic conditions. I just saw a person recently that was getting palliative care for a type of slowly progressive Lou Gehrig's disease. He's probably got years of life remaining, but because of the complex symptoms he's having and the decisions he's had to make about feeding tubes, respirators, and so on, which are different for Lou Gehrig's disease than they are for end-stage dementia, he's been involved with palliative care for quite some time and in a different setting. And so you can do that even for chronic complex illness, not just for end-of-life care. These two slides are just really highlighting, this is from the Journal of Palliative Medicine, Next Gen Palliative Care, and these references are in handouts. And this one is from the New England Journal, current and immediate past president of the American Academy of Hospice and Palliative Medicine. Both articles say the same thing. There are not enough specialized palliative care providers in the U.S. to meet the need, even if we produced everybody. It's probably not conceptually ideal anyway. I still strongly believe primary care providers, specialized providers in their disciplines ought to be doing the bulk of palliative care. It's just how do we figure out the collaborative generalist versus specialist models and work together to enhance that. What are those skills? Well, in primary palliative care, and here the word primary isn't so much primary care as it's any specialty that's not specialized palliative care. They're talking about pain and symptom management. You do that day in, day out. Managing depression, anxiety, I'd broaden that to say psychosocial and emotional and even spiritual issues that need to be addressed. Then basic discussions around prognosis. This is a key one. Goals of treatment, suffering, and code status. That's all stuff that you don't need to refer for. Specialized palliative care, again, tends to be more the complex symptom management. The folks where you've got more complex psychosocial dynamics, probably 2/3, I would guess, Sarah, something like that, of our consults are for quote-unquote goals of care. So a lot of times I'm going in and doing complex symptom management. A lot of times I'm not writing any medical orders. It's all the pulling the family together, having a family meeting, spending an hour doing what the hospitalists could do, but they don't have time to do. And in your office setting, that's another big challenge. So part of where we'll go with this is how do we do advanced care planning in a way that fits into the flow of a real world office when you don't have an hour and a half to spend on this? How do you do this effectively? I'm going to have a tendonitis in my thumb by the time I'm done with this. So some barriers to advanced care planning, some of it's reluctance to bring it up, and that can be, I don't think they're ready to have this talk. It can be, I don't dare have this talk, or I'm going to be stuck in this exam room for another half hour and I'm already running behind. Sometimes it's the belief they can't handle it. Always reminds me of that, was it Jerry Maguire? You know, no, it's a few good men. You can't handle it. I hear a lot from a lot of folks. I don't think the patients can handle this conversation. training. How do you have this conversation effectively without intimidating or frightening your patients? And then just that association with death. When you bring up palliative care, do they automatically go, isn't that like hospice? And I don't talk about palliative care in this setting. I talk about goals of care. And there are different ways to do it that are appropriate to anybody. It's not just for end-of-life care. Other issues, and this is some studies where they show fear of legal ramifications comes in. Again, time pressures, I think that's one of the biggest in most practices. What is the support system that's going to be out there for them if we do this? And, you know, do we have others to help out, social workers, et cetera? And then what are some of the different advanced directive types? So we'll go through these here. I'm just going to do a quick time check so I don't use up all of your time here either. So limitations on advanced directives, often you can't find them. Even in the EPIC system that Providence now uses, I can't tell you how many times on the banner it'll say pulsed none. I click on it and I can actually find a pulsed in there. So can you find them when you need them? You have to know how to look for them in paper charts or other things. I just read something recently about a guy that had this great advanced directive. It was in his lawyer's office. Family knew nothing about it. Didn't help a bit when he needed it. So, and then I mentioned earlier that very vague form of advanced directive that doesn't really tell you a lot. It's more a compass than a roadmap. So in your packet, you have a document called 5 Wishes. This is one type of advanced directive. Sir?
If I might just counter, or sometimes they're just white and narrow.
Oh, yeah.
You know, if I drop dead on the street and my heart isn't beating and I'm not breathing, this is what I want.
Yeah.
Or yes, no, and the document.
Yeah.
And, oh, okay, no, you come in, you've got a nice thump on your head, and your heart is beating, but you're not breathing very well, and you're incapable of making decisions. There's absolutely no direction provided by that document.
So what he's talking about is the issues of nuance, where you get something that says a very concrete decision that may or may not have relevance to the situation. So I don't want a feeding tube if I have advanced dementia, I'm declining, death is imminent, and it's just going to prolong the process. I do want a feeding tube if I have a stroke that's moderate and I'm going to recover my swallow function in 2 or 3 weeks. And so there is that issue of nuance that you have to take into account with any type of advanced directive. So in your packet, the 5 Wishes document, this is something, there's a website listed there. You can purchase these for your office. They're unfortunately not downloadable for free, but we use these a lot, and I really like it. The thing it does, I'll put a few other things, oops, wrong way. There are 5 different wishes. I actually work from the bottom up on this. Maybe I'll do number 4 first, but what do you want your loved ones to know that's most important when you have a serious illness? I often ask patients, or more often family members, if I have to know one thing about your mother that would help me take the best care of her, what would that be? And that's often a really informative question. So what do you want people to know? How comfortable do you want to be? Some people, they really don't like the idea of opioids at all. They don't want to take a lot. They don't want to be a junkie, whatever their things are. They don't want to be sedated. They don't want to feel goofy. Others go, I want to be pain-free. I've suffered terribly. I just do whatever it takes to make sure I'm not in pain. So they can really stipulate that. That leads up then to, well, based on what you've told me about how you want to be treated, what you want people to know about you, what level of comfort you want or don't want, well, here are the range of treatment options that we can offer and what we should or shouldn't offer. If somebody says, I want to fight to the bitter end, go out guns a-blazing, maybe, in fact, they do want to be full code even when we don't think it's the right thing. If somebody says, I don't want to make my family have to decide when to pull the plug, we then aren't saying we're going to withhold it. We are going to offer the treatments that honor your wishes. And this is not a part of that treatment complex. Depending on their medical condition, of course. And then up top, number 1 is absolutely crucial. If we do nothing else, eliciting who is the surrogate decision maker. A question I use, if you can't speak for yourself, if you were to be so sick you couldn't speak for yourself, who would you want to make your decisions? And that's not always the most obvious choice. It may be their spouse, it may be their children, but it may be somebody else. This is an advanced directive, but it's a really useful educational tool, and that's also in your packet. It's called Hard Choices for Loving People. They unfortunately recently updated their website, and I like the old version better. I'll just admit some bias here, partly because I could download it and print off a chapter in real time. But you can purchase these and give them to patients and families. The second chapter on artificial nutrition hydration tube feeds, things like that, is so helpful because a lot of people assume everybody needs a feeding tube or we're starving them. When in fact, for many people, the literature demonstrates that feeding tubes neither prolong life nor improve the quality of life, and in fact, they're probably medically contraindicated. End-stage dementia, many cases of end-stage cancer, if not most. And so this provides a resource to help people work their way through these difficult decisions. You probably recognize the pulsed form. This is for current conditions. So this is a physician's order, a provider's order. This actually has legal weight, and there's immunities built into it for people to respect it in most care settings. And so if the medics get called and somebody has a pulse that says do not resuscitate, they're not only allowed to withhold resuscitation, they're actually obligated to. I just read this morning of a family in Florida who is suing a nursing home and hospital who coded and put in the ICU on a vent for about 3 days their mother with end-stage dementia who had a very clear DNR order. And it'll be interesting to see how that lawsuit plays out. It's Florida, so they're more litigious than we are up here in the Northwest, right? So who ought to have a pulse? Well, anybody that's really clear-cut, I do not want to be resuscitated. If somebody says, I want to be full code, they really don't need a pulse all that much because it's the de facto position anyway. Really, it's when you say, I wouldn't be surprised if they died within the next year or two. You don't have to say, I predict it, just they've got late-stage COPD, congestive heart failure, kidney insufficiency. I wouldn't be a bit surprised if they're in their last year or two of life. That's an appropriate time for a pulse form. A healthy 35-year-old, an advanced directive is very appropriate. I always used to joke with my patients that if you drive on I-5, an advanced care planning document is reasonable. You think about the biggest court cases we faced, Terry Schiavo, Nancy Cruzan, Karen Ann Quinlan, all were young. Probably not coincidental, all were female. We won't get into anthropology here, but all were young, and they had these really important end-of-life decisions that needed to be made. Advanced directives, the conversations made a big deal. In both Cruzan and Schiavo, it was the fact that they had spoken about their wishes up front, and if they'd had advanced directives completed, we wouldn't know their names right now because it would have all been taken care of before it made the media. I'm not going to go through the pulse form in a lot of detail other than to say box A. I often hear people say their pulse form makes no sense because they're DNR in that first box and they still want stuff in the second box. Well, really, box A means if I find you pulseless and breathless, what do I do? So you live in a nursing home, you live in an adult family home, an attendant comes in, you're at home with hospice, your loved one comes in, and you're dead. Do they try and bring you back? The answer is no if you put DNR. The second one is what happens when you're not dead but you're dying. And so they come in, you have limited respirations, an erratic heartbeat. Do you want comfort only? Do you want intermediate levels of interventions, or do you want the full 9 yards done? So some people say, well, if I'm dead, from Princess Bride, I don't want to be resuscitated, but if I'm still potentially salvageable, yeah, give it every effort. So actually that inconsistency isn't as bad as it sounds. Antibiotics and artificial nutrition probably don't need to be on a pulse form because pulse forms aren't for us in the hospital. Pulse forms are for the medics. They should be on your advanced directive, your 5 wishes, but are probably not as essential in the pulse form itself. Again, I said it's intended for advanced directives. It requires a licensed independent practitioner or a licensed dependent practitioner to sign it, and a surrogate or the patient themselves needs to sign it in Washington and Oregon. Interestingly, they don't require a patient's signature. And the surrogate's wishes can, and in some ways probably should, override the pulsed if they're doing it in a way that's commensurate with the patient's values and goals. If it's one of those, now that mom can't speak for herself, I want you to do everything or I want you to do nothing, that's probably not fitting. But the nuance again, it's like your question. Somebody may have planned ahead, filled out a pulse thinking this. I just saw somebody yesterday who had a pulse that said full everything, but she had told her family repeatedly, I don't want to be hooked on a lot of machines, and she was dying of an intracranial bleed. And the family all said, oh, no, that's not what mom meant when she filled out that pulse. And so we were honoring her wishes to make her a DNR, even though her pulse said otherwise. The caption says, there's no easy way I can tell you this, so I'm sending you to someone who can. So part of the intent in this talk is that you're not the doctor here because I'm glad to take referrals. Unfortunately, like I said, we're limited to inpatient setting, but I would like to think that most of us can be the one that has that hard conversation. So breaking down office-based advanced care planning into 6 different steps for me is helpful. Now, I don't expect any, it's a little bit like the Kubler-Ross stages. I don't expect you to have these memorized. Not all cases go through them in order. Not everybody goes through all case, but it helps provide a framework for what the goals are of having advanced care planning conversations with patients and families. The relationship between the patient and provider greatly affect this dialogue. If you're just meeting a person, the dynamic is very different than if it's somebody you've known for years. And that cuts both ways. I was doing hospice and palliative care and family medicine at the same time, and I remember getting a guy with stage 4 lung cancer, but at a fairly high functional level, and I was really irritated that he didn't do chemotherapy because he was high functional status. It would have extended his life and in the long run would have provided benefit for quality of life. Meanwhile, as I'm a palliative care doctor, I'm seeing patients in similar circumstances going, what are they doing chemo for? And it kind of hit me. There's a different emotional investment in this long-term relationship that I bring in as a consultant meeting somebody for the first time, and it does have its own influencing effect on me as a provider, and I need to own that you know, it's different when it's somebody you've known for a long time. Secondly, you need to think about something like the stages of change model about readiness to have these conversations. You've got your pre-contemplators. I asked one guy, you know, what are you hoping for? And he said, a miracle. I said, well, what else are you hoping for? I haven't thought of any other alternatives. You know, he's really not ready to have this conversation. Your contemplators, they're starting to think about it. The people who are actually taking action, the people who are doing maintenance, you know, just like your other stages of changes. So how does this work? So the first idea is just to bring up the advanced care planning concept, you know, so that people understand what it is, why it's important, and to highlight we don't need to do all this today. And there are different ways you can do it. When Sarah and I do our role plays, we'll model a few different examples of how it can be done in the office setting in a way that's practical and workable. And some language you might use, you know, you're doing a health maintenance visit like a Medicare annual wellness exam. One of the questions on your check sheets ought to be, do you have an advanced directive? And maybe asking the patient in person, have you thought about your treatment goals? And there are a variety of approaches you can take with this. And that have you been involved in anyone's end-of-life decision-making? That's, again, very context appropriate. You ask that out of the blue, they're going to go, why are you asking me that? But if it comes up in a practical way, I just had this recently where somebody was talking about his father and what they went through at his end of life and said, well, you're thinking a lot about this. What have you thought about how you would want to approach this? Oh, yeah, I've talked to my wife about it, and that really opened up a conversation. Only took 2 minutes to have the conversation. Important stuff, and we could move on. Next up, what about the current state of health? So you start by kind of finding out, do they have an advanced directive? Do they know what advanced care planning is? That sort of thing. And then before you really dive into a lot of it, it's important to say, so what do you understand about your illness? Or what do you understand about your situation? Now doing hospital work, it's a little different than office work, but I hear everything from, I don't know anything, nobody's told me, to I was in the office a couple years ago and a guy came in for follow-up on his CAT scan, and I knew before I went in the room he had metastatic cancer. I went in the room and said, so tell me what you understand about your situation, because I hadn't ordered the CAT scan, somebody else had. He said, well, they saw this spot on my lung and they're trying to figure out if it's metastasized or not, and the CAT scan was going to tell me that. That's a very different conversation than if he says to me, I don't know anything, nobody's told me. So that's important to ask, what do you understand, so you enter the conversation at the right point. And then their overall functional status is going to have a big impact. Somebody that's robust, healthy, isn't really thinking that they have any serious illness is going to be thinking very differently about this than somebody who really recognizes that they not only are impaired, but they're becoming more impaired functionally over time. So some questions. What do you understand about your current state of health? I always like to ask, what do you understand about your situation? It's a little more open-ended. Have you thought much about what the future holds with your medical condition? One I really like to ask is, when you think about the future, what are you expecting? And they give a very concrete answer. A more often transcendent question is, when you think about the future, what are you hoping for? Different ways to get a sense of what are they looking towards when they think about their future. And then that what are you hoping for really follows under the values and hopes for quality of life. Asking questions about what level of disability would be acceptable. Recognizing that changes as people develop progressive disability. There was an interesting study where people were interviewed about what quality of life would be unacceptable to you. And a year later, many of them were re-interviewed when the people that were actually looked at in this study had deteriorated to that quality of life. Well, now that this is my only choice, I'm okay with it. A surprising number, kind of modified that. So you have to look at it in the moment. Where advanced care planning looks ahead, you need to loop back in the moment to make sure that holds. So asking, what provides meaning in life to you? Saw somebody on the ventilator this week where we were talking about, would he be okay living in a long-term care facility, bedbound with a trach and a ventilator, and his wife was, are you kidding? There is no way. He was an active outdoors guy. He liked to hunt, and as she kind of outlined all the things, not only that, he was a very proud man. To live like that to him would be worse than death. And so that kind of helps shape where are we going with our care from here. Asking, if you could think ahead and choose your ideal end of life, what would it be like? Most people are going to say at home with my family around me. Some people say no way at home. They don't want to be at home because it's going to be bad for the grandchildren, it's going to be bad for their spouse, there are a variety of things. I actually had to learn that the hard way with a guy that I was really excited that I got him into hospice and all that when I was a brand new doc, and he fired him and I couldn't figure out why. And he's like, I don't want to die at home, doc. That'd be awful. It was this little aha moment for me. And then establishing surrogacy, identifying, again, if you can't speak for yourself, who would you like to make decisions for you? Be familiar with the normal trends in the state. So in Washington State, spouse would be the first, adult children, back up. A legal court-appointed guardian would take precedence over any family, and a DPOA, durable power of attorney for health care, would take precedence over any family. So if I sign my brother as my DPOA, and my wife wants to go one way, my brother can actually overrule the wife in this scenario. Then if you don't have advanced directive documents of that sort, spouse and then adult children, and ideally adult children in agreement. I always laugh because in Idaho they had dentist listed somewhere in their hierarchy, which the only thing that told me is there was at least one dentist in the Idaho legislature when they passed their regulations. So you can ask, do you know what a surrogate is? Have you talked with family about this? I always like to ask, do you have a family member who's going to see things differently? And sometimes I have a little fun with it. I say, around here we call that the son from California syndrome, where the guy comes, hasn't been around for 3 years. He's often a high-powered business executive, used to being in charge. Everybody here's on the same page, and he comes in and stirs it up. And most families know family well enough to know what I'm talking about, and then you get a sense. And I've had then people say, would you give my son a call or give my daughter a call? I've got a niece that's in Montana who's in nursing school, and she's having a real tough time with this no feeding tube business. And so there are different ways to help families out that way. Oops. And then that leads into some of the more specifics about care, typically being cardiopulmonary resuscitation. I think it was in one of Dr. Fairbrook's patients back in when you were still a clinic at Panorama that I was in hospice, where I saw the patient was asked if they die, do they want me to try and bring her back? And she declined. So a pulse form is completed with a DNR status. How you phrase that really matters, because what we often hear is, so if your heart stops or you can't breathe, would you like us to do everything? And most people are going to say, well, yeah. Well, what do you mean by everything? Steve Panelot at University of San Francisco tells the story of that question being asked that way, and the patient says, yeah. And when they really broke it down, what they meant was, we want you to do everything to keep mother comfortable. We know she's dying. We don't want her to die in pain. We don't want her to suffer. So do everything, doctors, to help her. But of course, the automatic interpretation is, oh my goodness, this family doesn't get it. They want us to ventilate their mother, and that would be awful. That's not at all what they wanted. So you have to break down the language. And often I get, when you're working through that 5 wishes document upwards, you can actually then be a little more leading in a non-paternalistic way, a non-parentalistic way, because they've told you their values and goals. So you can say, based on what you've told me, it really seems that we would be at a point where if this were to happen, I don't think you would want to be kept alive in the ICU, hooked to machines, where your family has to make that difficult decision of when to discontinue life support. And a lot of people, that's not withholding something, that's saying, yes, you're helping me make a value-based decision that really honors my goals. And so the phrasing and the framing of the question is absolutely crucial. And then other life-sustaining measures come in there. Now again, this doesn't need to all be done at a single visit. In fact, it's probably optimal not to be. In a consult capacity, often we have to do this all in a single visit because it's just the way it works. But even then, it's often a 2 or 3 day process, sometimes even more. Sometimes it's a week-long process. I've got one young guy I've been seeing for a few weeks now, and within the next few days, we think a major transition is likely to happen. And having been involved over the last few weeks, there's relationship that's been built up that is going to facilitate having that conversation in a very different way.